a soft jelly inside to kind of extrude or protrude outward. Typically, because of that protrusion and the deformity within the disc, it typically puts pressure on the spinal cord, which is why we get a lot of neurological symptoms, such as sciatica, which is pretty much the most common symptom that they'll complain of when it happens. It's also a result of the combination of flexion and compression of the spine. Just a little bit of anatomy. So like I said, there's two layers. We have the outer layer, which is the annulus fibrosus. That's the tough layer that kind of holds the disc together. And then the inside is the nucleus pulposa, which is that jelly-like center, which is why we call it a jelly donut. It's also acts as the cushioning between each of the bodies of the vertebrae. So that thick piece in the back that we all know what it is, that's where they're located, and it helps with like shock absorption and all that good stuff. There's a lot of little ligaments that hold our vertebra together. So the ones that I focus on are the interspinous ligaments, ligamentum flavum, the superior and lateral costotransverse ligaments, and the radial ligaments, which basically hold transverse processes together, spinous processes, and all the bodies. And there's like a bunch of little ones that put the whole thing together. There's also a lot of muscles that act within thoracolumbar movement. And some of the ones that I focus on in particular were erector spinae, the multifidus, the psoas major, and the quadratus lumborum. And the two big nerves that excuse me, were affected in my case in particular were the femoral and the obturator nerve. So my case study is a 20-year-old male baseball player. He is a first baseman. He was in the weight room and he was deadlifting when he was doing a max rep, and when he came up, he reported that he didn't have correct form, so he felt an extreme sharp pain, and it went down his legs. So he immediately walked over to the treatment center. He was unable to perform really any range of motion without pain or limitation between thoracolumbar, so any type of rotation, especially flexion extension, they were all limited. So we actually had to do our evaluation with him standing up because he wasn't able to sit down because of that lack of motion. He also had his muscles in spasm, which he actually has a past history of bilateral erector spinae muscle spasms. It's happened frequently for him, but every single time they have resulted in, we do biphasic and he does his proper warm-ups, and he was back within 2 to 4 days for each spasm. He presented with pain directly over L4 and L5 when palpating. There was no swelling visible, but it was palpable, and there was no discoloration or deformity within the area. There was also no loss of function reported from him, but he felt the numbness from his glutes to about proximal to mid-thigh around the hamstrings, which was just on the right side. It was not bilateral, so it was just one side that he was feeling that on. We performed some special tests to rule out any other injuries like spondies, SI dysfunction, or a fracture. So we did a tap test, single leg hyperextension test, a Faber, and a Gaislin, which were all negative, but he did present some kinds of dull pain when performing the test, because obviously his range of motion is very limited already, so having him go through these tests was painful for him in some sort of way, but they weren't positive. We then moved on to a Wells straight leg test and slump test to test for herniated disc, both of which were very positive, and he complained of sciatica with both tests when we performed them. So we diagnosed him with a herniated disc, and we referred him to the team doc for an MRI, which he got 2 days later. Within those 2 days, we took care of him by giving him pain control like ice and stim, and asking him to not play time, not play, not work out, and limit as many ADLs as he could. And then when we got the MRI back, it was confirmed that he did have an annulus fibrosus tear, so that outer layer he had actually torn through, and that was confirmed, which you can see it kind of bulging out into the spinal cord right here. So we decided to do a surgical intervention, which we did an endoscopic dissectomy. I guess my picture cut off the last 2 letters, but that's what we chose. We did surgery because what I had read was that people who didn't have a surgical intervention would have prolonged symptoms in the future. So for his case, we wanted to make sure that we could try and eliminate as much possibility of having recurring sciatica in the future for him. And it was also most effective in common repair for lumbar disc herniations in particular was a discectomy, and it's safe and minimally invasive because it's endoscopic, so we're not making a huge incision. It's done with a lot of tubes and tools and pipes and all that jazz. So that was scheduled for a week later, so we did prehab with him by, yet again, eliminating all playtime and having him try and limit his ADLs to what he could handle and what was pain-free for him. We also did pain control, like I said, with ice and stem twice a day in the treatment center. And we tried to work pelvic neutral exercises and some range of motion just so that we could try and gain some of that flexion extension, especially before he goes into his surgery, making sure that when he's coming out, he's already gained something. So those exercises included like low sets of pelvic neutral where he would come in, he would do them before ice and stem. It would be like 3 sets of 5, just like we kind of do here in class. For range of motion, it'd be take 3 deep breaths as you're trying to perform the motion, try and get a little bit farther with those breaths. Obviously, he's not going to be going very far, but as much as we could, we got. So overall, rehab goals and phases. The goals were obviously to regain full range of motion in all planes, So rotation, flexion, extension, we wanted all, even lower body, just because his muscles were guarded when we had evaluated him. We also want ADLs with no limitations and 100% pain-free so that he can go on in life and walk around campus and not be in pain. And then ultimately increase the strength of his core and his lower back and lower extremities overall. I broke it down into 3 phases. Phase 1 was initial recovery, so it's going to be the first few weeks after he has surgery. Phase 2 will be the strength, balance, and proprioception when we start to incorporate more exercises in his rehab. And then phase 3 would be the sport-specific and functional moving within his rehab, and then the return to play testing at the end. So, phase 1. Week 1 is a lot of bedtime and incision care and recovery because he's just had surgery at this point. So the first week is making sure that he's resting. Typically they're on bed rest for the first few days, just not doing a whole lot of movement just because of lack of movement in the first place. They're not in pain, but they're just very stiff from having surgery on their spine. So incisions usually heal 7 to 10 days. We schedule an appointment to have him come in to see the doctor on day 10 to make sure that the incision healed. He did have inverted sutures, so it wasn't something that he had to get the sutures taken out from. So that was a lot easier, but we made sure that he paid attention to signs of infection or anything like that. But when he checked in, he was 100% good, healed, ready to go. Pain control in that first week as well. He was prescribed oral corticosteroids in order to help with the pain and inflammation down there. And then we did ice and stem, where he would do ice at home if he couldn't make it into the treatment center those first few days. And after the first week, if pain recurred and our massage and ice and stem weren't helping him, he was referred to an acupuncturist. Another big thing for the first week especially is making sure that the patient was educated, because he is dealing with his spine. It's a very important part to our, how we move and everything. And so we did what's called back school, which is basically just informing the patient on how to move correctly and how to have better posture. And for instance, going from a laying down position to sitting up, we don't want him to just sit up. It was we need him to roll to his side and then help push himself up and then get up. That way he's not putting a lot of stress on the lumbar spine and making it painful for him. And then of course, again, limit any ADLs that reproduce the pain or symptoms for him. Those were eliminated. So after week 1, week 2 begins, and by this time he is feeling good. His incision is healed. He's been ready to go. There's nothing to be super worried about. He's been pain-free for a couple days now. So we go back to working on range of motion with flexion extension as our main focus. We do lateral rotation and lateral bending, but those were never really limited too much in the first place. So these were our 2 main focuses for sure. And it's the same concept as before, where we have him stand and do it actively, and because it's hard for us to do passive or assisted, and we want him to be able to do the movements himself. So having him stand and perform those movements and taking those 3 breaths, and each time trying to get a little bit farther. So we would try and have him do that about 3 times a day, whether it was in the treatment center or at home for his own care. For lower extremity, we wanted to work on flexibility because he has been guarded and kind of immobile for a little while now, and he's probably really tight, so we want to get things loosened up again, because our lower extremity muscles have an effect on pulling our lumbar spine and our hips, which kind of all act together, as we know. So we focus on piriformis. We did a figure 4 stretch, 3-way hamstring with the bands or assisted, and then knee to chest, and then hip flexors and a simple flamingo stretch to get the quads. We also tried to have him do some yoga on his own time if he felt good about lower extremity flexibility. and we did simple cat-cow progression, and then cobra into child's pose and back. For core, we specifically picked movements for him. I did less exercises and more exercises that we can build onto, so that the athlete feels like he's progressing throughout the rehab. So I tried to pick 3 or 4 to focus on that I could build from. So we did dead bug, plank, and bird dog, which he started doing just a simple, like no arms or hands alternating or anything like that. And then for cardio, because he's been out of it and we want to keep him in shape so that it's easier for the transition into baseball again, we have him get in the pool, because the stress on land is ultimately too much for him to handle right now because of that shock absorption. We don't want to have the pounding on the ground constantly over and over, but we want him to get his heart rate up and his cardiovascular system going. So we put him in the pool, and we started him off with just 10 minutes walking in the shallow end with the AQX suits on. And then if that walking felt good, which it did after the first day, we had him start into dynamic warm-ups, which included like A-skips, butt kickers, high knees, and that was also with the suit in the shallow end. And if at that day the walking and the dynamic warm-ups felt good, then we would progress on. By day 2, when he was feeling better, we did make that progression into a deep water jog. So he continued with a 10-minute walk warm-up so that he was getting the blood flowing. He did dynamic warm-up so that we were working different muscles, and then we hopped him into the deep water, all under supervision with the AQX suit on, and we had him do just like 10 minutes of deep water jogging for about 60% of what he would fully do. Day 3 came around and he felt fatigued from the day before, so we had him perform the same thing. We didn't progress forward because we didn't want to push him past what he was already fatigued, so we wanted to acclimate him to the day before. Day 4, he felt great, so we increased the time for the jogging to about 20 minutes. And then day 5 came and he was still feeling really good, so we increased his intensity to about 80% with deep water jogging as he was still performing the walking and the dynamic warm-up, so that he has a proper warm-up before he goes and jogs in the deep water. Okay, so phase 2 is weeks 4 through 6. By this point, the patient should have full range of motion and his ADLs are 100% pain-free. Again, we have the progression exercises that work the strength of low back and lower extremities kind of combined. And then this is when we're going to start working on balanced proprioception, and we're going to continue to work on his core exercises, which now we can start incorporating, like I said, the progressive functional movements. So like the bird dog and plank is core, but we're also strengthening his low back while working and incorporating upper and lower body, which is the intent for those exercises. And then we also continue our cardio workouts in the pool so that he's still being acclimated to getting back to practice faster. So like I said, we build on dead bug, plank, and bird dogs. At this point, we're adding in arms and legs, and we're changing surfaces to make it harder for him within weeks 4 and 5. We also threw in RDLs because I think RDLs are a great way, especially for this injury, to help control lower body and like pelvic neutral, and have him have more sense of like what he's doing with his low back and his low body. So we threw in RDLs, and then again with wall squats with the physio ball. I really like that exercise, especially for this patient, because it emphasizes the control that he has with his low back and his low extremities. And we can do eyes closed, put him on the foam pad, make it difficult for him. It's another one of those exercises that we can progress for so that he feels like he's getting somewhere in his rehab. We also progress pool workouts, so we make the intensity harder. We can jump the intensity to 90% in the deep water. We can also make the jogging longer, so he's getting more endurance again for like base running and things like that. And then we threw in more core exercises to make it more challenging, but also not just have our core incorporated with the other exercises we're doing, like dead bug, plank, and bird dog. So we do bridging with leg extensions, which I really like that one because it's another thing that really helps him focus on his low back. And then we do crunches, pass-throughs, and bilateral crunches, which is just getting the core going. By phase 3, we're in week 6 through 8. By this time, we are transitioning his pool workouts onto land, hopefully. He can now sustain the force that he's going to be enduring when he's on land. So we're transitioning dynamic warm-ups and some of the jogging onto land. And then we're moving into our sport-specific movements and drilling. So the 3 things that we focused on were ground ball drills because he is the first baseman, his batting progression because he hits a lot, and throwing progression as well because he's a baseman, so he's going to be throwing. The throw progression that we chose was in weeks 5, we started off with just the dart band so that he gets the functional movement again before he just jumps into throwing. We want to make sure he's pain-free with all functional movement when he's doing the throwing motion. We do the same thing with ground balls as we use dart bands for him to go, and we can put resistance on him when he's doing it. Batting progression is the same kind of deal. We start him with wiffle balls, we go to real balls, and he changes percentage as he goes. And then by week 8, we're doing our return to play protocol. So the patient's taken through a practicing progression where he starts with a half day under supervision. If he's pain-free, he moves on to full practice under supervision. If he's pain-free, we go to full practice on his own. And by that time, he should be going back into regular baseball play. So, in conclusion, the complexity of the spine is very important to sports because of how it's centered in our body. I also think it's really important, like I said, to have those progressive functional movements and those exercises, and why I chose them to help them feel like they're getting somewhere when this is like a long period of time for them in rehabilitation, and that it may not be as common to have herniated disc or spinal injuries, but it's still extremely vital information, and we can apply most of the exercises and rehab that we do here with other lower extremity injuries as well.
I may have just missed this, so sorry for everybody, but you injured it during deadlift, right?
Mm-hmm.
Was there a certain way he was deadlifting that caused it, or do you know why?
Because he was at a max rep and he was trying to lift more weight than he's used to when he was coming down in that flexion already. When he came up, he didn't have his spine in the position that you want, so he didn't actually come into a good position. He was still in flexion while trying to lift a max amount of weight, so it put that compression on it and he wasn't positioned how he should be.
Was it an inpatient or an outpatient surgery?
It was an outpatient surgery. He went in, he had the surgery, and that day they sent him home.
Is that pretty